Good afternoon, everyone. Thank you for joining us. Today, we are discussing Medicare Advantage, financial impact, and external strategies. This is a continuation to the discussion that we had as a pre-conference topic as part of the Rural Health Conference back in October. This is a two-part discussion, and so today we're talking more about external strategies, the overall financial impact. January 15th, we have another session, and that one is more designed to talk about internal strategies. So if you are watching this recording and have any questions at all, please do not hesitate to reach out. With that said, Rob, I will turn it over to you.
All right. Well, thank you, Laura. So as Laura mentioned, we have a kind of a series here trying to follow up on our time that we had on site back in October. And so the presentation today is really almost exactly the same when we're talking about external strategies. Really what we wanted to do was spend a little bit more time, because I know we were a little time crunched when we were on site, to kind of talk about, as a state, how do we sort of coalesce around a cohesive strategy. But, to kind of start walking through the data, I'll turn it over to John Reagan, and he can explain, the exercise we went through with a number of Oklahoma hospitals evaluating what their degradation was, when we looked at the Medicare Advantage payments relative to the indemnity Medicare payment. So I'll turn it over to you for a few slides here, John.
Thanks, Rob. I appreciate it. And thank you all for listening to this slideshow. And the one thing I wanted to point out here with this slide here is kind of start us back to why we began looking at this, right? So back in 2010, when the payment provision for the Affordable Care Act was created, it really provided this incentive for Medicare Advantage to start really booming, if you will. And this is kind of the point in time where we really start to see the Medicare Advantage start in some of the bigger cities, and kind of move its way towards the center of America. And we'll kind of look at that in a few slides here. But 2010 is really when we started to see this kind of movement towards Medicare Advantage start. So between 2009 and 2017, the enrollment in Medicare Advantage increased more than 80%, right? So we really started to see things as we got closer to 2017, really started to see more and more Medicare Advantage plans coming into play. And then from 2018 to 2022, we saw another big growth from 37% to 48% of enrollees. So now we're getting really close to that almost 50% market share with our Medicare Advantage plans, close to that 2022 range. And as we can see with the last bullet point, what we've really been seeing is, and what we'll see in the next slide as well, is really that year-over-year growth when it comes to Medicare Advantage plans, to the point where we're getting to, if not exceeding, the Medicare Advantage plans to really taking over more market share. So next slide. So here what we're going to see is kind of a visualization of what we just talked about, right? So the pie chart on the left-hand side, we're going to see that over time, year over year, we've gotten to where Medicare Advantage plans are now the majority and not the minority. So by 2023, we actually have traditional Medicare taking a back seat at 49% to Medicare Advantage plans now being the majority plans. So as you can see here with the graph on the right-hand side, it's really been exponential growth year over year, to the point now where 2023 is one of the bigger jumps that we've seen year over year. So it really kind of shows that this Medicare Advantage plan situation that we're currently seeing is not going away. It's only increasing year over year. So it's not something that we can ignore. So all the things that we've been talking about from a pain point perspective is not anything that we can kind of ignore or push it aside anymore. We're really seeing this kind of grow year over year. And it's time to really understand, what do we need to do? What are the pain points? And how do we really understand what we need to do from a facility standpoint to really meet this problem head on? Now, what we wanted to do with this slide here is really identify and show that the Medicare Advantage plans really kind of started with the larger cities on the outskirts of America, in your Californias, your New Yorks, your Floridas, your Texas. And what that did was it didn't allow the penetration really to make it to the center of America, into the center portion until relatively recently. And I don't even know if we could even say that it's at full penetration even today. So based on the 2023 statistics, Oklahoma has about 40 to 50% Medicare Advantage penetration. But that could increase. There are definitely opportunities for those Medicare Advantage plans to still increase. So those pain points that we're experiencing today, I don't even know if we can say that this is where it ends. We could be still seeing more. And I think that's really important to understand that we're not quite to probably the pinnacle of what we could expect from Medicare Advantage plans kind of taking over. And so here what we have is, I'll let Rob kind of chime in as well for things that I'm not quite seeing here, but we really had reviewed 5 hospitals in Oklahoma. And what we're looking at here is the market, the penetration, and what did that mean financially for these hospitals? So the one thing that we wanted to look at here is really using our traditional Medicare payers as kind of our benchmark, right? So what we're expecting, what we see in a lot of contracts, is that our Medicare Advantage plans should be collecting identical to what our Medicare is collecting, right? And so what our data showed is very close to, if not identical to what we've seen at other hospitals, where that collection percentage is right around 51% from traditional Medicare. Now, what we also saw, which is identical to almost what we've seen at other hospitals, is where our Medicare Advantage is pretty far behind that, right? So we're not collecting nearly as much as we are in our traditional. So here, what we've seen when we took all 5 hospitals, we put them together, we saw that if you look at the very right-hand box there, we got 34% collection compared to what we were getting on our traditional, which is at 51%, right? So what does that mean? So that means that we're probably somewhere missing the mark, or we have an opportunity, if you will, somewhere between almost close to $4 million. And then we also have, when we're talking about market penetration, if we also believe that, like we were talking about in the previous slide, if we were also to say that we don't believe that our market penetration is where it's going to peak at, meaning that we believe that we're going to see more and more Medicare Advantage plans come into play, well, what does that mean, right? Meaning that if we're currently seeing a $4 million opportunity and we're still going to see more and more Medicare Advantage plans, where do we believe that if we get to 50% penetration, what does that even look like? And so even though the $4 million is an eye-opener, we're talking about if we think penetration is going to get to 50%, we're coming in somewhere around that $6.7 million mark, which is obviously a very large opportunity, especially when we're talking about rural America, right? When we're talking about resources that we know are very limited, resources that mean a lot to us. This is an area that I do believe that based off of what we're seeing here and what the data is showing us, based off of the 5 hospitals that we took as a sample, we believe there's a large opportunity here for us to really dive in and really understand if there is an opportunity this large where the data is showing us, this is something worth taking a look at and really understanding, okay, where is this heading? What do we need to do to take charge? How do we get control of this and really understand that if we haven't reached our full penetration yet and the opportunity is already here, well, how do we really make sure that we're not seeing more of it slip away or we're not kind of ignoring this problem? So I think that data is really, really important to look at. And I'll hand over to Rob to see if he has anything to add at this point about the data.
Yeah, no, I think you covered that well, John. And so, in January, Nicole and I will come back and, talk about what we're seeing when we go out to hospitals that, are some of the drivers of this degradation. But what we really just wanted to highlight here is, at that 50% mark, you're talking about erosion of 9% of your operating margin. And of course, as critical access hospitals, when we're thinking that, assuming they're paying the same as Medicare, it's at best break even, right? In many cases, not even quite that, because of course we've got non-allowable costs and sequestration impacts. We really can't, afford to take that kind of an overall operating margin hit. And so, the question we wanted to talk about is, well, what are we going to do about that? And the focus today is around, those external strategies. on how we, kind of, come around this. And, I spent some time really, looking at some of the different, grassroots forums, things out there like that, trying to see, what's everybody doing and looking around, in the industry to see, what are people doing to try to handle this. And I really, came up with, three kind of common paths that seem to be emerging. One of those paths is avoidance, right? Just basically saying we are not going to contract with MA plans. You've seen a lot of that occurring in Kansas for a period of time, and now you're seeing in Western Nebraska a number of hospitals try to really push this strategy forward. The second path is essentially lobbying, seeking legislative relief to some of the pressures that are associated with the Medicare Advantage plans. And then the last one is really to try to find a way to manage through this. And that's kind of, we'll spend some time focusing on that in the next session. We'll hit it at the highest levels today. And really the question we wanted to pose is, which approach is most likely to achieve a desirable outcome? And should we be working multiple strategies simultaneously? And so, if we think about, the avoidance strategy, essentially, this again is one that revolves around not having contracts with Medicare Advantage plans under the concept that if we don't build it, they won't come. I do think there are some challenges to that plan. One of those is, what's in your current contracts. And what I mean by that is if you have a contract with, say, a Humana, but perhaps for, a commercial book of business, is there language in that contract that actually allows the payer to force Medicare Advantage on you? So, we do a number of contract reviews for hospitals. And this is, one of the common pieces that we always call out for folks that is in probably, over 90% of the contracts that I've reviewed over the last couple of years, which is essentially the way the payers word this. They put language in the contract that basically says they get to add service lines. You actually, most cases, have the right to refuse that service line. But in order to do that, you essentially have to cancel your entire contract. So it puts the hospital in a very difficult position. And so then you also have to formally, provide notice. And so, it's always the question, right? When they deliver the information, they're adding another platform to the plan. Does it get to the right person quickly enough? Whose desk does that initial communication end up on, or whose email? That can sometimes be a challenge, but also, it really makes it a challenging conversation for the hospitals to have. And of course, sometimes, we run into situations where we don't even have great communication. We may even be missing a provider rep with an insurance company. And so those things can all run that clock on us as we're trying to work our way through it. So that's one potential challenge out there. And the other question is, how well do we think all of the surrounding hospitals are going to stick to that plan? Who's going to potentially view this as an opportunity to take market share? And so if that occurred, right, we have to ask ourselves the question, can we maintain enough efficiency to live on a 50% reduction in our Medicare market if consumers still choose Medicare Advantage plans and instead decide to travel to receive that care if we're not, in network? So, that's one of the, options that, we spent a little bit of time talking about. The other approach is lobbying. And the idea here is, basically working with our various advocacy groups to get governmental protection from negative Medicare Advantage outcomes. I've seen everything out there from, let's change the way in which critical access hospitals are paid to avoid this. Let's, exclude critical access hospitals from having to get paid by the MAs and stick those claims still going through the MAC if it's a COT. A lot of different ideas out there. But, one of the questions is, how do we coalesce around a common plan? how will unintended consequences be managed? Because again, sometimes our advocacy folks, don't think of all the various complications. So I've seen, one platform out there that says, let's get paid on a OPPS plus methodology for outpatient and then still have a true up. But what, from a regulatory standpoint, will we all of a sudden become subject to if we're paid under OPPS? Because there are a lot of things we are able to skirt around because we're not reimbursed under OPPS. And then, the last piece is, how likely is this to succeed given the political environment? Who's going to be that champion that's going to push this forward and get enough support in Washington to actually make something happen? So, again, there's just a varying number of complexities in trying to get, even a common platform. You can think about it within a state, but then you can even go to the national scale. There are a ton of different advocacy angles, and how does that play out when our elected officials in Washington are hearing from, various groups, right? You might be hearing from the Oklahoma Hospital Association, at the same time hearing from NRHA, at the same time hearing from AHA, and at the same time hearing from, other state hospital associations. So how does that all sort of get managed and harmonized? And the last one is to try to, manage our way through this. And this is, I think, one of the more interesting topics, which is the reason it's now a complete carve out. Because, when one of the reasons we started really looking at Medicare Advantage platforms is we started to realize that it's a pretty good litmus test of the overall efficiency and sophistication of a hospital's revenue cycle. So, if we take a look at kind of, peeling that apart, it's sometimes an indication of how well our contracts managed and negotiated. It's oftentimes an indication of how well our internal processes are working. Usually what we've seen is if there's a significant degradation when we look at the Medicare Advantage reimbursement relative to Medicare, usually there are a number of underlying revenue cycle issues that are sort of negatively impacting that. So, we have a number of challenges here as well. Do we have the right people and resources? As I'm sure everyone would agree, recruiting talented individuals to rural can be quite complicated. And of course, we sort of also have this cultural identity of, we wear as a badge of honor the number of different hats that we're wearing. But sometimes that means we're not, adequately balancing all of the competing priorities. And if we don't have the right people and resources, do we have a way to find them? And then really kind of the final piece here is, at the end of the day, assuming we can get the right people and really try to tackle this, will we still have enough leverage to be successful? Because quite often, as I'm sure you're all aware, our third-party payers are very crafty and very good at trying to wear us down and getting us to accept lower payment as opposed to just not getting paid at all, because that then gets them off the hook. And so, they've become very adept at doing that. And do we think we actually have enough leverage to, if we can really mind all our P's and Q's, dot all our I's, cross all our T's, and do everything right, do we really think that, we can sort of, win that long game? So, those are the three strategic areas. So, hopefully, I know we had a couple of folks join us here a little bit late. We can have some time, kind of, talking through those strategies here, and, kind of what everybody's thinking about that, and maybe where you're leaning and how we can try to come together, at least as a state, to, come up with some approaches, realizing there's probably not a right answer. So with that, happy to open it up to the floor.
Hi, Rob, can you go back to that slide that has the three approaches on one?
Yep.
Perfect. And there's also Rob's question at the bottom. You can unmute your own line. Please, if you feel free to put something in the chat. I'll watch the chat as well.
we've kind of gone back and forth on whether to cancel, get away from the advantages. Is that going to leave a bigger impact on our patients who have it? I mean, we've had several patients come in during the enrollment this year and want to know the differences between it. And we've kind of told them our perspective, and they've kind of gone in with what we're saying is they want to get away from it.
Yeah. So, I mean, it has the potential to. So I'll tell you, I guess the only personal experience that I have with this. So I'm originally from Southwest Nebraska. My mother, still lives on the ranch there. And, her local hospitals, the nearest ones to her, are two that chose to go the "we are not going to contract" route. So that puts her back onto traditional Medicare, which does have some, negative impacts. So, one of those hospitals is a critical access hospital. She didn't have the co-insurance burden for outpatient services with her MA platform that now she takes. So, that may influence her to go elsewhere for as many of those services as she can. I don't know. Those are kind of some of the complicated pieces here to that. But it certainly does have the potential, to negatively impact the local patient population, particularly during that transition year. And again, I guess that's one of the unique things, right? So I'll go back to that specific case. The two closest hospitals, one's a critical access, the other is not. So how does that play out?
We're kind of out here in Northwest Oklahoma, and a lot of the bigger ones around us, we're still an hour drive, but they are no longer accepting the advantages. So those patients are coming here.
Mm-hmm. So the question is that good volume or volume that actually increases the loss because we're not getting paid? Those are all the questions.
Right. Okay.
Now, again, right, there is a train of thought that if you're in an increasing market share, increasing volume scenario, which that may be, and you can actually get paid your MAC issued rates by your MA plans and collect it, then because there's no true up, right, you theoretically potentially always have the opportunity to create positive margin because the MACs are always behind and there's no true up. So to the extent your cost to charge ratios are going down because of added volume, you never have a payable to a Medicare Advantage plan. The trick is getting them to pay you those MAC issued rates and being able to do all of the things that are required to actually get those dollars collected. And, unfortunately, it all starts with what's in the contract, and are we sophisticated enough to live up to the language that's in the contract?
Okay.
Well, let's jump over to the managing side of it. And I don't necessarily, know who we have on here relative to the five that we looked at, but does everybody know where their MA payments are relative to their indemnity Medicare, or, is there a gap? Well, so I guess the question would be, assuming we know there's a gap, have we been able to drill down as to, what drives that gap? And I'll invite Nicole, briefly to jump in here, at any time. But, we see a number of things that occur, right, all the way from, contract through, the ways in which we're managing the contract. So, one of the big things that we see out of the gate is, oftentimes they'll put a hard stop at 96 hours versus honoring the 96-hour average. And so, if we have a patient who's there that fifth day, that ends up, being uncompensated care. That's a contract structure issue that oftentimes, we can negotiate our way out of. We've seen a lot of challenges out there around, just authorization issues. So, for instance, Sometimes some of the MA plans are sneaking in a skilled nursing rate on the rate section of the contract. So, at first glance, it all might look right. It says, we'll pay your inpatient per diem, we'll pay your swing bed per diem, we'll pay your outpatient cost to charge ratio as issued by your MAC. But they'll also, sneak in some level of, skilled nursing language. And then they do a really good job of getting, case management or whoever is getting these authorizations for those post-acute patients. And they get the authorization as a skilled nursing patient. Then we've got them, sitting in what we think is a swing bed status all the way until we actually go out, bill that claim out the door. It doesn't pay the swing bed rate because they say, oh no, you got authorization for skilled nursing, not swing. And then we, don't realize that when it comes time for our cost report, we needed to have changed, the categorization of that because our system wasn't tracking it properly the entire time. So, right, maybe we could have perhaps gotten it as an NF day, which wouldn't have hurt us, assuming we're at least collecting, that statewide average. But we don't realize it. So then what it does is it ends up watering down our swing bed rate and actually being a big negative for us. So, we see those types of things out there.
And just to piggyback off of what Rob said, I think that really highlights the importance of the financial and revenue cycle folks and the clinical folks working together and creating that collaboration when it comes to really having a strong strategy to deal with your Medicare Advantage from many different aspects, from inpatient to outpatient to swing. Having both sides working together to combat that is where we really see successful organizations.
Right. Well, if we can wander into the danger zone, talking about lobbying, is there anybody willing to share their thoughts on, what you think about what you see out there? All right. Well, perhaps we can, round on, some of these things at the end after we've seen and talked through, a few more of these presentations. And so, I don't want to, hold everybody up at lunchtime. I think that's, the end of what we have to share today. Hope to see you all back in January, and I'll turn it over to Laura to close us out here.
Thank you, Rob. And thank you all who joined and are watching the recording. We will reconvene in January. That discussion, we will be looking more at internal strategies. If you're watching the recording or for those on the live call today, if you leave here and you have questions or, oh, I wish I would have asked this, or how is someone doing this, or what are you seeing? Bring that, you can email it to me, but also bring it with you on January 15th so we can have a larger discussion. Rob, Nicole, John, thank you so much for your time today. Everyone have a great day and have a great holiday season. Thank you all.
All right. Thank you much.
Thank you.